Good morning to everyone. It's Thursday, it's 10:01, so it's time to have fun at Enjoy Science with another super talk, very interesting talk on immunotherapy and colorectal cancer by Dr. Michael Overman. So we have to thank Dr. Overman for his time to be with us. And of course, I want to thank to all of you who are the attendees, because without you, such webinars cannot ever happen. I have to thank, of course, to Emily Lang, who is taking wonderful care of this webinar, to Anton Blender for registration, and to remember you, most of the talk are registered, so you, your friends, your colleagues, everyone who you know love science and love medicine can go on the Enjoy Science site and to listen talks from this year, last year, 2 years ago. I want to thank, of course, to Dr. Giulio Draeta for hosting the webinar, and of course to Ignacio Vistuba, because our department, Translation Molecular Pathology, took over on hosting the Enjoy Science. And with this, of course, I want only to say a few words about Dr. Overman, because all of us in MD Anderson and outside, we know his wonderful contribution as a clinician scientist. And I think he's a personality who very nicely synthesizes what it's all about, the beauty of this place. A wonderful clinician. He is professor in GI medical oncology, who is focusing on the research and understanding how to improve the clinical trials for cancer patients, which basically it's what brings the patient here and what brings the hope and the advance in the life for these patients. I don't want to say too much. He has a wonderful training, John Hopkins MD, then going to UCLA for residency, and finally being here as a faculty at MD Anderson. Super publication, all in top journals with very interesting and very innovative clinical trials. And Dr. Overman has a lot of contribution in cancer networks outside MD Anderson, connecting the institution with other institutions for the success of clinical trials. And in fact, today, it's a very interesting talk on immunotherapy and colorectal cancer. So Dr. Overman, Michael, thank you for being with us and good luck with your presentation. We are all very curious about the data. Thank you again.
Thank you, George. Really happy to be here, and thanks to the Enjoy Science team, and thanks to all the attendees for joining. Really nice introduction, George. And yeah, I think we're going to kind of give you a story of where we started and where we are currently in regards to kind of immune therapy and colorectal. And it is a story that starts, a while back, and one that, we played kind of a key role in developing. And I think it's kind of interesting, the interplay between kind of, basic science kind of knowledge translating into the clinical space and how that kind of develops over time. So I'm going to start here, and we're going to kind of go through this agenda, which is this kind of, just kind of immune therapy, colorectal, kind of some of the early efforts and some of the big randomized controlled trials that were done. And then we're going to really dive into this subtype, this mismatch repair subtype within colorectal cancer, which is really the key subtype that kind of helps delineate immune response and non-immune response. And there's a lot of interest kind of behind why that's the case. And then we'll talk about the clinical data and kind of where we stand now with approvals and current clinical data. And so to start out with, so this is back, right, back at the beginning, right? So these are kind of the first kind of PD1, PDL1 studies that came out. These are all colorectal cancer patients from these phase 1 studies. Right, so you got 0 of 18, 0 of 19, 1 of 14, 1 of 45. So pretty low signal for colorectal cancer, one would say, right? So there are a few hints, right? And so that one study I showed you there, 2010, that one colorectal patient was an MSI high patient or a patient with deficiency in mismatch repair that we'll talk about. That came out kind of after we kind of proposed our concept, but clearly one would say, pretty low level of success in colorectal. And that's kind of borne out here if you look at some of the bigger data sets that happen here. randomized controlled trials, colorectal cancer at the bottom there, looking at atezolizumab and various combinations. Atezolizumab is an anti-PD-L1 agent. No difference, no benefit, right? Those curves are pretty much overlapping with kind of the standard of care therapy. The up top waterfall plot is the idea of, well, let's take PD-L1 positive colorectal cancer and treat that subset with pembrolizumab. And again, you have kind of one responder, and that responder turns out to be MSI high, right? So there's clues, right? That the potentially there's this, subset that's kind of rare that may be a responsive patient, but on a big picture basis, the data is really negative for immune therapy in colorectal cancer. And then here would just be, what about combination therapy, right? So our kind of, would say one of our most impactful immune checkpoint approaches would be CTLA-4 and PD-L1 based therapy. And you can see here kind of two examples. So one is durvalumab and tremelimumab. In 119 patients, you have kind of one responder. And then Checkmate 142, which wasn't a randomized study, but you had 1 out of 20 patients responding to the combination, right? So combination doesn't appear to be, really the answer to kind of the colorectal cancer challenge of immune therapy activity. And so that leads us to this kind of mismatch repair space, right? And so there's many different mechanisms to repair DNA, right? You can see kind of these here, and I think we're all fairly familiar with a number of these. And there's one that's mismatch repair, which actually is kind of involved in repairing single kind of base pair insertion and deletion events. And we know this well because this deficiency, when inherited, generates Lynch syndrome, right? So patients that have an inherited deficiency in mismatch repair have Lynch syndrome and are predisposed to cancers, primarily endometrial and colorectal cancer, right? So that's kind of the space that we're used to looking for mismatch repair. MSI high is an inherited cancer syndrome. Now patients can have deficiency in mismatch repair from inherited, Lynch syndrome, or you can also develop it sporadically, and so by mutation or methylation events. And historically, we've known about this, Lynch syndrome for a number of decades, and so we've actually been testing for this to find these patients. And these tumors are kind of unique in that they have this they're characterized by this lymphocytic infiltrate. They have better outcomes, and they have this really kind of interesting stage distribution, right? So you have your high rate in early stage, and then a much lower rate in metastatic population. And so that's one kind of interesting clue here. We're looking at about 4% of metastatic patients. So on studies where you're enrolling all comers, you may have 1 out of 20 patients that's MSI high, right? So it's a really small subset for the metastatic patients. And so one hypothesis for this stage distribution effect, prior to kind of everything I'll show you kind of now, is that there was, immune recognition of this tumor given all these lymphocytes, right? So the tumor is recognized, and that helped prevent metastatic spread, right? It kind of kept the tumor in check and limited the spread of development of metastatic disease. Okay, so deficient mismatch repair tumors, what do we know about them genomically? And I think this is where the first clue about this subset really being interesting for immune therapy comes from. And so the top figure is just 141 colorectal cancer patients. And I kind of show it because I just think it's so interesting, the dramatic difference, right? So you have these red events, which are microsatellite instability events or mutations and kind of that generate frame shifts. So again, if you have one base pair insertion or deletion, which is kind of shown down there in the example of the TGFR beta R2 gene, what you do is you shift your kind of reading frame. And so what happens is you have kind of these unique kind of microsatellite events. It just commonly happens at areas where you have DNA repeats. The polymerase slips and inserts an extra, codon in areas where you have repeats of the same kind of the same kind of codon in your DNA. And so the characterization of deficient mismatch repair is errors in microsatellites, hence it's called microsatellite instability high, and they tend to be frame shift mutations. And so the top figure shows the high rate of mutation. So quantitatively, a lot of mutations, right? The rest of that figure, that flat line is actually most of colorectal cancer. There's a few blips there that are likely polymerase epsilon mutations. And then at the bottom, what you see is that because you actually have a mutation that generates a frame shift, you generate actually multiple altered amino acids potentially before you have a stop codon. So these mutations actually are very immunogenic. It's not just one amino acid you're changing, but you're potentially changing multiple amino acids. And so that's kind of the figure at the bottom, in which you look at your colorectal cancer population, you take your mutations that are due to microsatellite instability high patients, and then you look at predicted neoantigens, and it's almost a 3-fold higher rate of predicted neoantigens, right? Because of this fundamental frame shift mutation phenomenon. So it's a tumor type where we have high mutation burden, and you have qualitatively very immunogenic mutations, more neoantigens kind of per mutation. And so what we know now, this is a great tumor for immune therapy, right? That's kind of what this all kind of tells us. But back early on, this was kind of more of a hypothesis. We can find these tumors, right, by the classic approach as you look for protein loss by immunochemical staining. You can also look at variation in your microsatellites. Classically, we did that by polymerase chain reaction. Now you can do that by next generation sequencing. So all of our next generation panels are kind of identifying these patients. And that's kind of how we identify these patients, and it lets us identify them kind of across different tumor types. Okay, so that's just kind of background, just to kind of give you a sense of what we're talking about. And a lot of that was known to some degree in regards to the high mutation load, and not so much maybe immunogenic mutations, but definitely the high mutation load and the infiltrated tumor types. But fundamentally, we actually entered this fray based on data like this, right? So this is fundamental kind of lab-based data, really interesting back in the time. This is 2012, and I think people will kind of recognize this and say pretty obvious, but you do this simple experiment. You take, a carcinogen, you induce cancers in mice, those that have immune system, those that don't. More cancers develop in those that don't have immune system, right? The immune system is able to regulate a cancer development. And if you look at those tumors that get eradicated, you actually find, TIL that recognizes mutations, right? So this idea of kind of a tumor antigen or a mutated tumor antigen is kind of the key driver of an immune response. And then here was actually 3 other articles, and these were kind of these was the data set we used to propose our study. Again, looking at this kind of rare event where when you have an immune system that seems to work, a lot of this was actually related to vaccination or tumor-infiltrated lymphocyte kind of therapy. You can find a mutation that is very recognized and very presented by the immune system, right? So really kind of high binding and shown by the immune system, and that is what's being recognized. And so this idea of kind of mutations as the driver for immune response, right? So I think we all accept this and know this as reality now, but this is kind of the concept, and those were the data sets that led us to actually propose this study. And so this is actually just pasted from the original investigator-initiated concept I submitted back in 2013. We actually, didn't know what BMS's development strategy, so we actually did PD-L1, but they clearly went forward with PD-1, which their agent, which is nivolumab as we now know it. Again, the first approval for nivolumab was at the end of 2014, right? So this is kind of pre any checkpoint approval. And we proposed the concept based on kind of what I've told you, that, mutations are potentially what the immune system's recognizing. So let's look at a subset that has high mutations, and that's kind of microsatellite instability high or polymerase epsilon. It's kind of the proposal we did. This went to BMS. There's a lot of internal discussions, and this is kind of what came out of that. And this study is one that we led and launched at the end of 2013, so in that same year. It turned out to be a colorectal only study, so they were didn't want to do a tumor agnostic approach. In retrospect, that was probably a bad decision on a business side, because this mutational marker was the first tumor agnostic indication, right? So we kind of had to propose that, but it was only taken forward in colorectal. Also just kind of deficient mismatch repair and microsatellite instability high patients is what we went forward with. And you can see here, this is the design. It was kind of nivolumab, and then depending on kind of activity, we would kind of explore nivolumab or explore nivolumab and ipilimumab. And so this is kind of the study that we led, and that led to a lot of different data sets. And I think this is kind of, you know, the current kind of understanding, right? So I think people have probably seen this figure before, but kind of makes the clear case that within colorectal cancer, there's two different types of colorectal cancer, right? So you have your deficiency in mismatch repair, that's kind of up there, and you have your proficient, which is way down there at the bottom, right? And as you might expect with the data we've seen from immune checkpoint, level of mutation correlates with immune response, right? But we were kind of predicting that based on really kind of that fundamental basic kind of lab data that I showed you. And so what's happened since we started this process is that we have a number of approvals for this subtype of cancer. And so in metastatic colorectal cancer, there's approvals in the frontline, refractory. We have approval in endometrial and approval in solid tumors. So a tumor agnostic approval for cancer patients that have a deficiency in mismatch repair or microsatellite instability high, right? So that's kind of where we've come. And that first approval came in 2018. And the approval for nivolumab and nivolumab ipilimumab was predicated on that study that I showed you that we started in the end of 2013. So study to approval, 5 years. And so let's kind of jump into some of the data. I've given you kind of the background of why we got into this space, kind of our proposal and kind of how that played out. And this was, so this is pembrolizumab data. They did a study that actually was interesting because they actually included proficient mismatch repair patients. So they kind of included both, right? They kind of said, let's look at kind of deficient and proficient, and they enrolled kind of a enriched population deficient to have equal numbers. And I think the data is really interesting because it really shows you what I've kind of been alluding to, in that the biomarker for immune response in colorectal cancer is a deficiency in mismatch repair, right? It is a very unique looking genomic cancer, and it is a very different cancer in regards to response, right? And this is the type of data you'd want. I mean, if you want a predictive biomarker, you would look at this data and be like, this is fantastic, right? Green benefit, red do not benefit, right? I mean, you know, it's kind of green and red, black and white, right? So really kind of dramatic, and really kind of is part of the reason that we've had such success with this biomarker going forward, and the reason it was the first tumor agnostic biomarker approval by the FDA ever, right? And so there's been a lot of different PD-1s kind of explored. You can see them all here, right? Lots of good kind of waterfall plots, lots of consistent activity, colorectal, non-colorectal, endometrial. I think the one point I'd make is that there is a progressive disease rate that exists. So it works really well, but not in everyone, right? And so we'll talk about that a little bit later on in regards to kind of what are we doing about that. But the most recent kind of development in this space was actually this study. So this is the Keynote 177. This kind of took the data I showed you before, which was single arm studies demonstrating activity, and said, what about frontline metastatic colorectal cancer, chemo versus pembrolizumab, right? Kind of that kind of is immune therapy better than chemotherapy for frontline colorectal cancer patients with deficiency in mismatch repair? And this was the study, and this study was positive, right? So, and pretty dramatically so, right? You can see there kind of the green arm was a pembrolizumab, much higher kind of rate, especially if you look at kind of further out the 24-month rate in regards to chemotherapy. So basically for this tumor type, immune therapy is by far the best systemic therapy kind of we have. And that actually was kind of the follow-up. And this is why immune therapy, you know, as a medical oncologist, we really like immune therapy, is kind of this example I'm talking to you about today. And we'll dive into a little more of why I like it. But one reason is that it works really well, and it's a lot less toxic, right? I mean, quality of life is better than chemo, and your grade 3 toxicity rate is an absolute reduction of 44%, right? that is dramatic, right? 22%, 60% grade 3 toxicity. Those are high grade toxicities, is an absolute reduction of 44%. I mean, that is just really dramatic in regards to a therapy that works better and is tolerated better. I mean, those are the type of therapies that we want for our patients. So the other reason we like immune therapy is this story. So this story is a little bit early. You know, we often declare cure when patients, you know, have been out for about 5 years without recurrence. And we actually are now approaching that time point. And so I'm going to make the case that this therapy for this type of cancer is actually a curative therapy. And so a few points to make that case. Here is one example, a patient I actually saw last month. He was one of the first patients that went on our study or not the first patient, but went on our study, the Checkmate 142 with the Bristol Myers Squibb study I talked about with nivolumab, and really interesting in kind of what clinical trials and what novel therapies can do, right? I mean, he had a number of surgeries, a number of chemotherapies that weren't successful, got onto nivolumab on a clinical trial, and over 5 years later, he is cured of his cancer. And he is a lumberjack, and he does all this, you know, lumberjacking out in the Northwest, and has been very active and basically normal and cured. I mean, it's really pretty dramatic and shows you kind of the potential benefit we can do. And then here's another data set. So this is actually from the study that I led, the Checkmate 142. This is actually the combination cohort, the nivolumab plus ipilimumab cohort. And here is the data from one of the first presentations we did with 13 months kind of follow-up. This is back in 2018. And then here is the follow-up, 51 months follow-up. And this is one of the reasons we say, you know, we think this therapy is clearly a prolonged benefit, but cure potential, because you see that flattening of the curve, kind of aka what we would see with our kind of classic, you know, surgery type curve. So continued benefit that's persisting. And now we have, you know, a 48-month rate, right? So 4 years out, that's pretty long. And for context, right? So this therapy, nivolumab ipilimumab, was approved for refractory metastatic colorectal cancer patients that were MSI high, right? We also have approval for refractory colon cancer as well. And so that approval example here is regorafenib, okay? Both are approved. And what is the benefit of these two different therapies? It's dramatic, right? So regorafenib for metastatic colorectal cancer that's refractory versus placebo, you can look at the curve, that dashed line is 1 year, right? There's no one out 1 year, right? That curve goes down basically to zero around 1 year. And so, yes, there's a little bit of benefit, but there's no prolonged benefit, right? And so what we are gaining by identifying this group, giving them the right therapy, is just dramatically more than what we have kind of on a unselected population basis of regorafenib. And then the final point that I'll make kind of on this idea of cure, again, we're going to have some data at this coming ASCO that I think is going to kind of also support this point as well. But, you know, if we're curing patients, then one would expect there's no cancer left when you look at tissue, right? And so here are some recent data sets, one that we led, in which you look at patients with localized MSI high deficient misfolded repair cancers that went to surgery. And so those are the kind of the pie charts there. You can see the past complete response rate, 69%, 60%. So high past complete response rate. And then we had a data set of patients here at MD Anderson and also a group in France where we took metastatic patients that went to surgery and said, you know, what was left who went to surgery, and almost all of them had a past CR rate. So clearly there's a little more selection on who we're taking to surgery. You know, we take patients to surgery that are probably responding and doing well. So there's selection there, but clearly this therapy appears to have the ability to eradicate cancer at the, microscope level, right? So clearly that curative potential would be possible. And I think that's kind of what we're seeing. And so that's kind of the reason why I think we have a lot of excitement. I think melanoma has been pretty clear in demonstrating that cure fraction. I think we're at the point now, 4 or 5 years, where we can say the same thing for this subtype. Okay, so I'm going to kind of change gears a little bit and talk about, what are we doing in the next, 15 minutes about, the future iteration. How do we do better on a therapy that works well and has really been a game changer for patients? But I would make the case that it's been traumatic, right? We have now curing patients that we didn't cure before, but let's cure more patients, right? I think there's even more kind of need for us to aggressively raise that progression-free survival curve, right? Because we have the potential to do it. Let's kind of make that even greater. And so the challenge you see here is that this is the PFS and the OS from the Keynote 177, that pembrolizumab versus chemotherapy. And there's that overlap early on, right? So there is a group that is not benefiting from immune therapy. And actually the chemo group does a little bit better early on, and then they kind of cross around 6 months. And likely that's driven by the fact that about 30% of patients progress on first restaging. So that means that 2 months you get a scan and they're progressing. And so that's the group that clearly we need to do better on, right? And we see that consistently across all the data sets. I showed you that before. And so what are we doing to kind of try to figure out who these patients are? And I'd say that's still a work in progress. It turns out it's not quite as simple as you think. I didn't show you data here, but there's been a lot of data looking at DNA sequencing with the idea of, are there DNA mutations in interferon signaling, DNA mutations and antigen presentation? And that actually turns out to be extremely rare. So that's not the simple answer. One of the data sets that's been pretty clear cut is make sure that your test is correct, right? So we use immunochemical staining or use PCR. And here's an example of a data set where there was a fair amount of difference between local and central labs, right? So one is just to make sure that your patient has what you think they have. The other data sets are looking at, how much tumor mutation burden, predicts outcome. So a higher level seems to predict better outcome. These are really small data sets. Also, a lot of the low TMB in these patients, are they really MSI high patients? Are they misclassified? Would be one question. And then here's a more recent study that just came out at the end of last year that I thought was a really great kind of study looking at this, that actually makes the case that if you look at kind of a cohort of MSI high patients treated with immune therapy, they did 2 different cohorts validations. There isn't, if you look overall at TMB or kind of your lymphocyte infiltrate, there's no actually difference there in kind of outcome. Those are kind of the graphs down there at the far right. But what they kind of make the point of that there are cases that don't respond, and those tend to be kind of this low TMB. So there's like a threshold effect for TMB. So it's not necessarily a continuous variable, but a threshold effect. So if your tumor mutation burden is less than 12, you don't benefit. If it's higher, then you do. And that kind of goes along with this idea of, mutation amount. And so that's kind of one of the best kind of predictors we have, is just verifying your biomarker is correct, and then having this kind of, I think, threshold effect for kind of tumor mutation burden. Okay, so how do we incorporate that into making advances going forward? And I think, 2 different approaches that are ongoing. And so one is, I showed you data with pembrolizumab, right? So single agent PD-1 therapy. What about more aggressive immune therapy? And so one classic case would be nivolumab and ipilimumab, CTLA-4 and PD-1. And so this was actually a single arm cohort in the front line. So the same setting as the Keynote 177 study that actually had a much lower progressive disease rate. I showed you before 30% with pembrolizumab. This is 13%. Response rate is much higher. That's kind of the progression-free survival curve that kind of flattens around 70%. So it appears that combination, non-randomized fashion, may be more active than single agent, right? So better immune therapy, right? This subset's immune responsive. Let's give better immune therapy. The other approach is, well, how do we address this crossing over? And maybe we should do immune therapy and chemotherapy. And this is happening in a lot of different areas. I do as an example here, non-small cell lung cancer, where they had the same problem. So they had this crossing of the curves due to kind of this group that progressed and didn't benefit from immune therapy. And if you actually do immune therapy and chemotherapy, you negate that crossing of the curves, right? So that's kind of shown there at the bottom when they actually did that kind of 2 different studies, and they did different approaches of immune therapy and chemo versus just immune therapy versus chemotherapy. And so that leads to these 2 studies, right? So here we have a study. The top study is an NCTN-led study that I'm part of, looking at chemo and immune therapy versus immune therapy. And then the bottom study is a Bristol Myers Squibb kind of supported study looking at the idea of monotherapy versus combination immune therapy, right? Pretty straightforward. And those are actually ongoing and rolling and probably readouts in the next few years, and will be kind of the first big studies to help us address, how can we do a little bit better? Now, there are some other innovative approaches that I'm going to talk about here, kind of the end of my talk in regards to kind of options. And so one is a company, this is a company called Noscum that we're working with that actually has a very interesting approach where they looked at the shared mutations across a whole host of microcellular instability high cancers, primarily colon and gastric. And then they developed a vaccine approach in which there's a cassette that encodes these shared mutations. And because you have so many mutations in these tumor types, you can actually cover 95% of tumors with one kind of pre-set up cassette, right? So this is a case where you don't have to personalize your mutations because there's so many mutations that are actually common across the various different HLAs and different mutation types that you can actually have a shared vaccine approach. And so that's kind of been studied, and I show you here data at the bottom of that's kind of their vaccine approach plus pembrolizumab in this case. And you can see kind of encouraging activity in small numbers of patients. I also think this is really interesting and being explored by others at MD Anderson, Eduardo Villar Sanchez in particular, looking at this early on, right? This therapy works really great. What about prevention, right? You have Lynch patients that get cancers. Can you prevent? PD-1 therapy prevention is a little bit tough because there are rare but real serious side effects, but a vaccine approach would be much more amenable. And so there's kind of work looking at this idea going forward in kind of a prevention space, which is really exciting. And so along that line of earlier kind of settings, I kind of have talked up to this point about metastatic patients, right? Well, there's a lot of patients that, of tumors that get resected that aren't metastatic. So what about those patients? So this is the classic kind of, well, let's do added to adjuvant therapy, right? So you have a resection and then you get chemotherapy, but for this tumor type, what about resection and chemotherapy plus immune therapy versus chemotherapy, right? And so this study is enrolling. This is the ATOMIC study and is going to tell us if that's, a benefit adding immune therapy early on after surgical resection. I think some of the more interesting data is actually neoadjuvant therapy. So prior to surgical resection, this is one of the first data sets that came out. They gave nivolumab, ipilimumab, then took patients to surgery for localized colorectal and had just tremendous amount of kind of path response in those patients that were deficient in mismatch repair, right? So that's the red bars there. You can see 20 of 20 patients had a response and the path CR rate there was extremely high. And so again, kind of supporting how active this therapy is. And we launched a study that's here that we presented at ESMO last year and we'll hopefully have out later this year, which is kind of looking at that same thing where we did, pembrolizumab neoadjuvantly before localized deficient mismatch repair tumors. And we enabled patients to go to surgical resection or to actually watch and wait. So we have a group of patients here in which we need longer follow-up that actually have had great responses from immune therapy and we didn't do surgery. So is immune therapy active enough to replace surgery in these patients is kind of the question that this study is going to suggest and give us some preliminary data for. And I think the data is going to be very supportive that potentially is a case. Again, really a very active therapy replacing our tried and trusted surgery as an option going forward. And so you can see here in the patients that did go to surgery, vast majority of them have past CRs. So that's kind of the blue there. Some didn't, but a lot of those had actually responses as well. Though 2 pancreas patients that we enrolled didn't do as well. It appears that colorectal seems to be a little more responsive than other tumor types. The other point I'm going to make as we talk about kind of other novel approaches, and this one I find kind of just fascinating, so I thought I'd make the statement here, is that there's this really interesting correlation between fusions and MSI high. So this is the data kind of showing that 2 different data sets, looking at fusion rates in colorectal cancer. And if you dive into that, what you see is that the vast majority of fusions in colorectal cancer are in MSI high patients, right? So that's kind of that one example there, 0.2% versus 8%. And so there's this MSI high fusion kind of correlation. And then if you dive into that even deeper, what you see is really fascinating is the people that have these fusions are the sporadic patients that have RAS wild type status and MLH1 methylation, right? And if you find that tumor or that patient, your rate of finding a fusion is almost 50%. I mean, it's really kind of just amazing. And so it's really interesting that, I think there's a lot of interest with targeting fusions, and clearly this subtype is a really great subtype to look at and has a really, you can select for an extremely high rate of fusions. And a lot of these fusions would be targetable fusions, RET, NTRK, that we have good drugs for. Okay, so what are some other kind of novel approaches that we're exploring? And I'm going to kind of lead you with two that I think are very interesting. And so one is kind of predicated on some data we did, which is not overly surprising, but these tumor types are characterized by a lot of immune system. They're recognized by the immune system. And so there's other checkpoints that are activated, and LAG3 is another big one. This again is kind of a marker that often is more expressed in exhausted T cells. And so we have a study ongoing looking at a combination of PD-1 and LAG3. This is actually through the NCI match approach. And then another study that we're conducting here at MD Anderson, this is another investigator-initiated concept, which is really predicated on some fascinating data from melanoma, in which microbiome modulation can lead to immune therapy reactivation, right? So really just fascinating interplay between the microbiome and the immune system. And so two different clinical studies that I show you up top from melanoma, in which basically they take the microbiome from a melanoma patient that responded to PD-1 therapy. They take that microbiome and they transplant it into a melanoma patient who did not respond to PD-1 therapy. And then what you see is that non-responder with microbiome transplantation, the same immune therapy, converts to responder in a certain fraction of patients. Really just kind of fascinating. And so we have the same study here looking at that for MSI high cancers. Again, a tumor type high mutation load, just like melanoma. And so can we see the same findings with microbiome modulation in this subtype of patient? And so for the final kind of 5 minutes, I'm just going to switch gears and talk a little bit about the tumor agnostic kind of space. And this is, I think, is interesting and really, aligns with kind of what I've talked about before for colorectal. The data sets are much bigger for colorectal. It's the more common cancer. We have more experience with it. But microsatellite instability high deficient repair is seen in a number of different tumor types. I kind of show you some data here. This is from NGS sequencing from Memorial Sloan Kettering. You can see here in the number of different tumor types where you have high rates, and some, interesting tumor types you might not think about. So adrenocorticoid is on there, germ cell, soft tissue sarcoma. And no matter what tumor type you are, you have this biomarker, you have a high chance of responding, right? And so this is the data set. This is the FDA label that I show you there on the left side that got the first FDA indication for a tumor agnostic indication, which was for solid tumor patients with deficiency in mismatch repair or microsatellite instability high. And you can see why. The color doesn't really matter if you look at that waterfall plot, right? All tumors seem to have a benefit with therapy across the board. And we've seen that with other tumor types. So dostarlimab is another one that recently got the same solid tumor agnostic indication. And here was their data and similar. We've also published on other kind of subsets. So this is the work we did through MATCH, which was the first MATCH study arm published, looking at nivolumab for non-colorectal deficient mismatch repair patients. And so how do we engage on the tumor agnostic approach, right? So we have a lot of different tumors that are metastatic. How do we find this rare kind of biomarker? And I think this is a good discussion topic that we can talk about. I think clearly we're moving in the field to where we're getting, molecular data on kind of all cancer patients. I think the costs are declining. The ease of doing a large panel, next generation sequencing panel is getting easier. Next generation sequencing panels now are actually able to call out microsatellite instability high. So you can kind of get your mutations, your fusions, your amplifications, and your MSI high call all together in kind of one analytic kind of effort. We can do protein expression, immunochemical staining. IHC is a pretty simple and kind of easy way to do it as well. But so ASCO kind of recent 2022 publication that I show you here that basically states what I show you here. So they think deficiency in mismatch repair should be evaluated on patients with metastatic and advanced solid tumors who are candidates for immune therapy. I'm not sure who are candidates for immune therapy. I think my interpretation of that would be people that are candidates for therapy, right? I think if you can't get therapy, then your PS is very poor. There's other issues, but in general, I think this kind of says testing and evaluation to find this subset should be considered on all cancer patients, basically. Now they do note that you should look into the prevalence and kind of have that factor in. Now how that factors in is the key question, right? And I'd make the case for the common tumor types, like the top 10 I showed you, we should be testing all those patients. Because I think finding this subtype, I hope I kind of made the case, is really impactful because we actually can now cure this group of patients, which otherwise, with metastatic cancer, we wouldn't be able to cure. And I think that's pretty dramatic and something we should be working hard to find these patients to kind of have that goal. And so in conclusions, I think this unique genomic subset is really kind of defines an extremely responsive immune therapy group. And that kind of, over time makes more sense, but was kind of something you can hint at way back in 2013 when we proposed our idea. We do have randomized data now, right? That one data set I showed you, that's the only randomized data that exists, but clearly immune therapy beat chemotherapy for colorectal cancer that's deficient in mismatch repair. I'd probably make the same case. I think that probably applies to all deficient mismatch repair cancers, so we don't have data in a randomized fashion to say that. And then I think there are tumor agnostic indications for this subtype, and that really brings up the question of identifying this subtype of cancer and finding those patients. And so that's my last slide. I'd like to say thank you for the opportunity to talk to you all today, and happy to have questions now, and happy if any other things via my email or touching base after the presentation and session as well. So thank you.
Thank you very much, Dr. Overman, for your presentation. Really interesting, amazing presentation. We have a couple of questions here. So the first question is, did the FMT combined with immunotherapy in these patients lead to a higher induction and maturation of tertiary lymphoid structures?
Yes, so I think that it's kind of what happens from microbiome modulation and immune therapy response, I think was the question, Linda. Is that correct?
Yeah.
Yeah. So I mean, great question. I mean, I think there was great preclinical data, kind of mouse modeling data, and then I showed you the two studies from melanoma, which really proved that clinically there is real meaning in kind of microbiome modulation. I don't think we have the answer to that. I think tertiary lymphoid structures, clearly there is correlation in different data sets, and we actually presented some data in colon cancer. In microsatellite stable cancers, I didn't talk too much about it because the immune response right now is really rare. We do see it, but it's extremely rare. But in certain cases, when you do see that, there is some correlation with tertiary lymphoid structures. We've kind of seen in a data set we published in clinical cancer research. But with microbiome, I don't think we know. Yeah, is it inducing that? Is it a certain kind of population of bacterium that matter? We just don't know. It's very early. I think the challenge with microbiome is a lot of different data sets in different tumor types don't have consistency of what is correlating with benefit, right? So I think it's a very early field, and I think a very fascinating field because we don't fully understand how that interplay is happening.
Thank you. So we have other questions here. Will you prioritize immunotherapy or GI trials?
Yeah, I mean, I think in a big sense, partly for the cases I made today, I think, as a medical oncologist and I think pharmaceutical companies as well, I mean, there's directional change to immune therapy, right? And I think the reason is that if we have success, the outcome is just so much better, and that's kind of shown from that, regirafenib, FDA approved drug. That FDA approved drug, gains us, the treatment versus placebo group on average 6 weeks more life, right? That was the benefit of that study, was 6 weeks overall survival benefit, right? Which is pretty limited. But if you're looking at kind of the immune therapy, you're potentially curing patients, right? Which is like, that's not 6 weeks. That's, that's years and decades and just different ball games, right? And so, I think we want to be in that ball game. We don't want to be in the 6 week ball game, right? We want to be in that like, let's get more ball game. And so I think that is the fundamental driver for kind of the transition to immune therapy. Now, I think it's not as easy as the subtype I've talked about, right? And that's where I think there's a lot of effort and research, but I think that's worthwhile, and that's where we should be putting our effort, because success will be so much more meaningful. It's kind of what I anticipate. And so, yeah, so our portfolio at MD Anderson for GI cancers is immune therapy heavy, no doubt about that.
Thank you.
So, Dr. Haverman, thank you for the great lecture. This is Alessandra Ferraioli. I connected late, but it was fantastic. There is another question from the question and answer that asks, how does the information translate to MD Anderson caregivers? In other words, how quickly can current providers hear your discoveries and implement this strategy in the patient that are currently treating here at MD Anderson? So I think the answer is, how quickly do you think the field will move and will become standard?
Well, thank you, Dr. Ferraioli. And Dr. Ferraioli was my teacher back when I was a youngin. So I'm honored to be talking with her as a panelist today.
I think he surpassed his teacher very well.
So no, I mean, it's a great question, right? I mean, I think, I will say that when a therapy is really active, it does drive practice change, right? So I think there was a fairly rapid incorporation of testing in colorectal cancer patients just because of the activity. I think the data really drove patients to recognize that and do it. I do agree, though, we tend to under-test. If you look at all the data sets for whatever, molecular testing you want to see, it is under-tested. And there's no doubt about that. And so I think there are efforts where we need to kind of push forward and do more testing. I think the other issue is, the testing in other tumor types, it gets a little more complicated. If your expectation for MSI high patient is 0.1%, should we be testing all those tumor types to find it, right? And that becomes more of a kind of health economic kind of question. I would say for that one person, it definitely is, right? Because it potentially can be a game changer. But I think we're moving towards the idea of broad testing across the board. I think that's helped by kind of these panels that can do everything, that are kind of lowering costs and making it easier, and more drugs that are available that we can engage on. But I think it's really important that we stress, to caregivers, to community, the importance of molecular testing. I mean, I think that is probably the take-home point that I would say, because it really starts with that point. I mean, you have to have the test results to be able to engage, right? If you don't have the test result, you're kind of dead in the water. And so I think it's really important that we kind of change. And I think it is changing, right? I think, but I think you'll find in the junior, medical oncology population, molecular testing is like, you have to have it. It's like part of their growth, their development as oncologists. But, for a lot of older oncologists, we didn't do this back when we started treating, right? And so, I think we just need to kind of stress the importance of getting these molecular markers to kind of, the vast majority of metastatic patients, because they really are game changers. And I think the more caregivers or patients are aware of the importance of molecular testing, I think that actually helps our case, because I think one of the critical things when I see a patient that comes in, I'm like, what is your molecular testing, right? And the more they're aware of that and show it to me, I think that really is a great education and kind of advancement across the board for all parties in kind of a patient's kind of cancer story.
Yeah, no, totally agree. And I think the field is moving very quickly with more labs offering, even outside of academic center, all those panels. And as you said, the cost is coming down and they are becoming more aware, so the patients themselves can educate and request them. I have one more question from the chat. It says, can you speculate how many MSI high CRC patients in the US will receive pembrolizumab as first-line treatment? I think they're asking in percentage.
Yeah, no, I mean, I think so. That study, the Keynote 177 study, I showed you was a fairly recent study. So, it came out very beginning of last year, I believe, or the end of the year before. So we're kind of a year or so in. It's FDA approved. I think, the data I showed you is pretty straightforward, right? Your progression-free survival curve is a lot better. I think, and the point I make, the curves do cross. So I think one could argue, where do you care? But if you're a patient, I mean, I care about the 2-year or 3-year. I mean, that's what I really care about, right? Where I am in 3 months, it's more where I am in a year or 2 years. And I think pretty clearly immune therapy is dramatically better than chemotherapy if you look at that time point of kind of 2 or 3 years. And so I think most of these patients, if they're identified, are getting immune therapy in the front line. I think that is the case that we're seeing. I think the issue is, when do you get your testing back, right? A lot of times we see patients, you order the testing takes, a month. And so sometimes there's delay in results. And so, we at MD Anderson, because of that, often do immunochemical staining, which turns around in a few days to get that result because it guides our therapy in frontline. We also order next generation sequencing, but then that comes back, 3 to 4 weeks later. But we have the data on this to determine that first therapy. And so I think that practice pattern it makes a lot of sense. I don't think it's necessarily being done across the board. And so I think some patients start chemo and then they post-fact realize they're MSI high and they might get immune therapy in the second line. But if you look, again, it's 4% of metastatic, colorectal cancers. How many stage 4 colorectal cancers are in the United States every year? It's around, we say 50,000. There's also some relapse patients from kind of localized. So it's a large number of patients that are getting this therapy in the frontline United States.
Great. Yes, I have some more congratulatory sentences on how good your talk was, but I don't have any more questions unless there is anyone else that has any burning questions. Oh yeah, there is one that has come around, and that is, I wonder if PD-L1 or PD-1 expression matters.
Yeah, so we looked at that. I mean, it makes great question, makes a lot of sense. It does not, so there is no correlation of PD-1, PD-L1 expression for microsatellite instability high and determining kind of that outcome. And I kind of talk a little about tumor mutation burden, but a lot of other markers have been looked at, and there is actually no clean marker to help us besides probably that best kind of low TMB threshold kind of idea. I think that's probably a practice pattern that makes sense to me. But again, a lot of our data sets are small, right? I think I showed you some of that. And so that's one of the challenges. And I think we're going to see better refinement going forward, in the future in regards to kind of what some of those biomarkers are. And I think some of the phase 3 data, as I showed you, is going to make a difference. And I'm very interested in the combination immune therapy. I think, I have a bit of a bias here, but when we talk about patients like this, we're really, I think I talk to them about, our goal is a cure fraction. I mean, my goal is to cure you with metastatic colorectal cancer. I mean, that's a great goal, and I think the data supports it. And so increasing that cure fraction, I think, is really important. I think if I was a patient, I would really care about that. And so, more toxicity for an increased cure fraction, I think is actually a pretty reasonable trade-off. We do that a lot in cancer care, right? We give adjuvant therapy to patients, with drugs that have chronic toxicities. You could talk about breast cancer or colon cancer. when we know we're just helping, you know, a small fraction of patients, right? We're helping maybe 5 or 10% of people, but we give all these patients, you know, toxic therapies in the adjuvant setting. And so I think this idea of, you know, toxicity and cure benefit, I think is pretty logical, makes sense. And I think that is the one question I think that's really outstanding for me is that, you know, should we be doing more aggressive immune therapy? Because I think the data suggests we are in the long-term curing patients. And so for me, I think that does bring up the question of, you know, more aggressive therapy to achieve that.
So there is a follow-up question on this point, and it says, if PD-1 or PD-L1 expression in tumors is very low or none, how the inhibitor target works? Basically, what's the rationale for seeing the work of the monoclonal antibody in patients that have low PD-1 or PD-L1 expression? And I will actually add to what kind of a heterogeneity do you have within the tumor in terms of like metastatic site primary for this type of expression for checkpoint inhibitor expression?
Yeah, no, so the probably the best data set is that study I showed you from gastroenterology that was just published, that they actually looked at different areas within the same tumor to kind of ask this question of heterogeneity, because, you know, microsatellite really high tumors, a lot of mutations, you might predict a lot of heterogeneity, right? And so you have a lot of difference across different sites of tumor, and they correlated a site, we know, high lymphocyte infiltrate, a site with low lymphocyte infiltrate, and they kind of looked at various different factors and really didn't see anything clearly delineated between those different sites. And I think the issue with, you know, PD-1, PD-L1 expression is it's, you know, it's a process in regards to kind of immune response, right? So where you are in one static point, you know, is one static point. And I think as we do therapy, we actually change the point in time. And so, you know, expression, I think, could very well change as we do our therapy for these tumors. And so you're right. I mean, you have to have the target there to some degree, right? I think that's very true. But I think it is there, it is expressed, just a matter of how high expression do you see, right? But I think that's one point, that you don't need high expression for this tumor type. The other point is that I think PD-1, you know, it changes over time as the immune system reacts to the tumor. And so I think it's very possible that we're engendering more of an immune response, and then that then subsequently upregulates kind of the expression. And so you have more target expression as you initiate the therapy.
And just as a naive question from a leukemia doctor, what strategies have you looked at to increase this level of expression in the GI setting? Have you looked, for example, at radiation, low dose radiation? Because I know that has been done in other type of cancers.
Yeah, no, I mean, I think you're correct. I think I'd probably maybe say just two points there. I know we're kind of running out of time, but yeah, you give, you know, a therapy of radiation or some ablation to kind of release tumor, make more antigens, you know, kind of increase activity. That hasn't really worked out in general in just colorectal cancer. I can speak to, you know, microsatellite stable colorectal cancer. There's some really interesting data that the Maya study that just came out, that they actually took temozolomide, an alkylating agent, with the idea of inducing mutations and then giving nivolumab ipilimumab. That was the study. It was a very interesting study with the idea of, yeah, can you kind of induce an MSI high phenomenon or a high mutation load that then would turn the tumor into immune responsive tumor type. And so there was a small group of patients that had success with that approach. So they treated a large number of patients with temozolomide, like around 100, and then there was maybe 30 that they actually had stability, that they then gave immune therapy to, and out of the 30, they had like another, you know, 10 or so that had probably benefit. So the benefit appeared to be more short-lived. So it wasn't, I would say, necessarily a clear success of that concept, though it was a little bit of a proof of concept, which I think is really interesting. And I would agree with you, Dr. Ferrajoli. Yeah, can we actually, you know, prime the tumors to become more immune responsive? And I think that's clearly one idea. And I think, but still needs a lot of work, because that approach, which was predicated on some good mouse data that worked, it didn't quite work in humans.
Okay, perfect. I think we are done again. Thank you for this wonderful lecture. Congratulations for all the work you're doing in your field, and for the institution in general, and it was a pleasure to have you.
Thank you for having me. Appreciate it.
Thank you.
Have a
Thank
good
you,
day, everyone.
everyone. Bye, 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 bye.